Good evening, moderators. Kangavel sir, good evening.
Good evening, Dr. Ashish. Has Kanagavel sir joined? He told me he's in an OT. He might be late.
Okay, I don't mind. I am ready.
Right.
So,
Mathur sir, will start?
We can start.
Yeah.
Yeah.
Can you make your screen full screen? Presentation.
Yes. Ma'am, is my screen visible?
Yeah.
Fully
Just a
visible.
disclaimer, the presenter and the examiner both are from the same institute, but we can have a healthy discussion anyway. So go
sure.
ahead.
Okay, ma'am. I'm starting.
Go ahead, Ashish.
Good evening, respected sirs and dear audience. I am Dr. Ashikes. I am a third year DNB resident from Sir Gangaram Hospital, New Delhi. Today I am presenting before you a clinical case on right left fossa lump. So, coming to my case, I present before you the case about my patient who was 60-year-old male XYZ, was a married gentleman, farmer by occupation, hailing from Bareilly, and who has lower middle socioeconomic class, presented with the OPD with chief complaints of pain in the right lower abdomen for 2 weeks, presence of lump in the right lower abdomen for 1 week, and fever and loose stools for the past 2 days. History of presenting illness. My patient was apparently well 2 weeks back when he developed abdominal pain, which is acute in onset, rapidly progressive. The pain was initially felt around the umbilicus and later shifted to right lower abdomen in the same day. Pain was sharp and colicky in nature, exacerbated with walking and coughing. The pain was not radiating and was very severe, for which he had taken over-the-counter medication. Pain improved and it became dull aching and diffuse over the right lower abdomen. The pain is not related to food intake. My patient also noticed a lump on the right lower abdomen region, just insidious in onset and progressive in size, and attained the present size of his palm in the last 1 week. This swelling did not increase or decrease in his size with walking, coughing, lying down, etc. My patient also complained of multiple fever episodes for the last 2 days, which settled with medications, reaching up to 101 degree Fahrenheit with associated setting and myalgia. My patient also had multiple episodes of loose stools up to 4 times per day over the last 2 days. So this was my history. Coming to my negative history, my patient didn't have any history of vomiting or nausea, no history of anorexia or significant loss of appetite. There was no history of hematemesis or melena, no history of constipation or obstipation, no history of urinary symptoms such as dysuria, frequency or hematuria, no history of similar abdominal pain episodes in the past, no history of weight loss or chronic constitutive symptoms, no history of evening rise of temperature, tuberculosis, contact or prolonged cough, no history of trauma to abdomen, no history of chronic bowel disease, or altered bowel habits prior to this illness, no history of an inward discoloration of eyes, no history of hemoptysis, or no history of worsening of pain with the leg movement. Coming to the past history, there was no similar illness in the past, and no surgical interventions in the past, no comorbidities, no history of tuberculosis or contact with tuberculosis, and no history of radiation exposure. Coming to the personal history, my patient had almost normal bowel and bladder habit, except for the last 2 weeks where he has loss of appetite and loose stool for the 2 days. He has sleep disturbed now due to illness. There is no history of allergy to any drug, completely vaccinated, no additions. Family history, no similar illness in the family, no history of diabetes. He has diabetes history and mild hypertension in the family, but no history of any cancers in the family. Treatment history, no other significant treatment history. Summary of history. A previously healthy 60-year-old gentleman presented to the OPD with complaints of acute onset abdominal pain of 2-week duration, initially periumbilical with subsequent migration to the right lower quadrant, later becoming dull aching and localized, aggravated by movement and coughing, managed with over-the-counter medication. Patient developed progressively enlarging right left fossa lump of the palm size with multiple intermittent high-grade fever and multiple episodes of loose stools over the last 2 days. This is my history.
Yeah, Ashik, I'll stop you here. So, basically, in your history, you said that there was an insidious onset. So, whenever you are presenting an acute case, it's never an insidious onset, right? There was something. Can you next slide?
This side, sir. acute.
Yeah, next slide. Yeah, so insidious in onset. So your lump in the right lower abdomen, since it's a history of 2 weeks, it's pretty acute. It's obvious, right? And he had an acute pain and he had vomiting. He had acute symptoms. So it's never insidious, right?
Okay.
So you don't have to mention that. Okay. So everything else was pretty okay. There were a number of negative histories that you said.
Yes, sir.
Can you go to the negative histories?
Yes, sir.
You said that, yeah, no history of yellowish discoloration of the eyes. So, what are you ruling out by yellowish discoloration of eyes?
We are discussing a case on right ilia fossa. So, first we are ruling out that the patient doesn't have any involvement of the liver or jaundice, because in sepsis, etc., the patient can have jaundice. Also, if we are talking about any malignancy, there will be metastasis to liver. So, in that case, also patient can present the jaundice. So, to rule
No,
out,
no, I disagree. What kind of metastasis will actually cause yellowish discoloration of the eyes? Liver metastasis per se will not cause yellowish discoloration of the eyes. And secondly, he is not in sepsis, right? So, the sepsis is a very loosely used term that we use. So, first thing is not sepsis. So, metastasis per se to the liver will not cause icterus. It's
there
only in specific conditions
not
where,
in the causes yellow discoloration.
which one?
If there is nodal metastasis to porta,
Yes, yes. But that is only in few cases, rare cases. In CA gallbladder, if it moves to the porta, only then there will be yellowish discoloration of the eyes, right? Okay. Secondly,
then,
why hemoptysis?
sir, to rule out tuberculosis, pulmonary tuberculosis, etc.
Okay, fair enough. Why hematemesis?
Sir, hematemesis also, mm, hematemesis and melena to rule out bleeding diathesis, sir.
Very unlikely.
Okay.
So I suggest when you are giving your negative history should be specific to the first differential diagnosis that you are giving,
Okay.
right? It should not be a list of negative histories. So no examiner will be impressed with the number of negative histories that you are saying. It should be relevant negative histories. So
Okay.
there was no history of vomiting or nausea.
Sir, no.
Okay, but I think if you would have asked the patient properly, he definitely have had some history of nausea. You cannot have an appendicular lump, which we are expecting in this case, without a nausea, right? So yeah, any other questions do we have? Priya, do we have questions from the audience here in the chat box?
Yeah. So I'm Dr. Mathur. I'm just coming in.
Hi, Dr. Matharan.
See that, yes, negative history that what you pointed out. Now he talks about his history of loose motions, and he doesn't qualify loose motions with what? Is it the frequency? Is it the watery? What is the color of the loose motion? Does it contain blood? Does it contain mucus? See, when you say the patient has a history of loose motions,
Sir.
you have to qualify it.
Yes, sir. Couldn't qualify it.
Oh.
The loose motion, it was more stool content, sir. It was not watery and it was not mucus. Patient was telling he had stool content. He had 4 stools, maximum up to 4 stool frequencies, sir.
Yeah. So,
And there
And
was no.
so
okay.
when there's a history of loose motion, what comes to your mind?
Sir, we will have to rule out gastroenteritis. Then,
Gastroenteritis, okay. And there's a lump, as you said, the patient noticed a lump after a week of onset of symptoms.
yes, sir. Then, then, sir, if in
And you
terms of
said there's no history of vomiting. When it's a
yes,
gastroenteritis, there is gastritis and enteritis. There is always, as was pointed out, there will be nausea or vomiting.
yes, sir.
Okay. All right.
And also with this kind of an acute thing, I don't really know. I'll ask your differentials right now. So no anorexia or no significant loss of appetite doesn't really ring well. A patient with an acute abdomen will not feel hungry. So if you ask properly, there will be some anorexia, will be some loss of appetite.
Yes, sir.
Okay. So based on your history, can you give us a differential diagnosis? You have not examined the patient yet.
Yes, sir. Sir, my differential diagnosis will be any disease involving the ileocecal junction, mostly.
When you have summarized the history, come to the slide.
Okay.
Yeah.
Summary of history, sir. So it is 60-year-old gentleman. We presented with complaints of acute onset abdominal pain for 2-week duration, which is initially periumbilical with subsequent migration to the right lower quadrant and later becoming dull aching and localized. The pain was aggravated by movement and coughing and it was managed with over-the-counter medication. Patient developed a progressively enlarging right iliophosaal lump of the palm size with multiple intermittent episodes of high-grade fever and multiple episodes of loose stools for the last 2 days.
Okay. So your differentials based on your history, only history.
Sir, it can be an appendicular lump, sir, because the symptoms suggest of an acute appendicitis attack, followed which the patient developed an appendicular lump. Also, the presence of high-grade fever in the last 2-3 days suggests that patient might have had an appendicular abscess also. Then these are my two main differentials, sir, according to the history.
Okay. So would you like to give any more differentials, or you are good with it?
Uh, Sir, I also suspect ileocecal tuberculosis in this patient, but acute onset pain are not in the favor. But I still have suspicion for ileocecal tuberculosis also.
Yeah, ileocecal tuberculosis or a contained perforation that might have happened at the ileocecal junction, right? A contained perforation. He is not, frankly, he is not in peritonitis, but yeah, since it's been 2 weeks, so a contained perforation is also one of the differentials.
Okay, sir.
Any more questions, sir?
Yeah. See, there is a loose motions. How do you explain the loose motions?
Sir, patient has irritation, bowel irritation, sir, small bowel, large bowel irritation,
Why?
to localize peritonitis.
Abscess, you were saying, right?
Yes, sir.
Okay. Any other differential? 60 years old gentleman, he comes with acute abdomen, okay, which looks like shifting pain, and you are right in saying that it could be appendicitis and so formation of appendicular lump and with the infection now. Anything else can happen which will give rise to similar symptoms in a 60 years old gentleman.
Ileocecal psoas abscess can have, sir, ileopsoas abscess.
Sepsis will present with the primarily with the pain in the epigastrium shifting to RIF. What the ileopsoas sepsis will present with primarily?
Ileocecal abscess primarily present with pain radiating to the back, sir, lower back, and aggravating with movement of legs.
Yes, yes. So that is not there. So why you are putting that? Anything which can be closer to the appendix. Okay, I'm giving the hint.
Mm,
So it can have a similar type of shifting pain. In a 60-year-old gentleman. Will you keep that diagnosis or will you not? Any differential diagnosis?
sir, malignancies of appendix, sir.
Malignancy, yes. Can the malignancy present like this?
No, it will not have an acute presentation, sir. It will be more insidious.
Hmm.
And the symptoms will not be like this, sir. It will be, no, malignancies will not be. In my case,
Can it perforate?
sir,
Hmm? And form a lump then.
perforation of any malignant ulcer can happen, sir.
Hmm.
Dr. Ashik, what sir is trying to point you towards is what other things do we look for whenever suppose you are operating a patient for acute appendicitis? What is the other one important thing that we look for?
That is Meckel's diverticulitis.
Right.
The perforation of a Meckel's diverticulum can form lump.
So can there be diverticulum in the cecum also?
Sir, cecal diverticulitis can happen, sir.
Diverticulitis.
In
Can
Crohn's disease, it can happen.
it form a lump?
Sir,
Have acute presentation?
sir, it can form, sir.
So then why you are not giving any differential diagnosis?
Yes, sir.
Okay, fine.
Okay, sir.
So
So
basically, diverticuli can be there on both the right and the left side of the colon. Symptomatic diverticuli are more on the left, but yes, there can be diverticuli on the right. If they undergo inflammation, there can be diverticulitis presenting with a similar kind of a symptom.
Okay, sir.
Yeah. So please go ahead.
So these are my differential diagnosis: appendicular mass or appendicular abscess. Then chronic disease involving terminal ileum. Then what's are told Meckel's diverticulitis and perforation of the diverticulum or diverticulitis.
Yeah, cecal diverticulitis, not necessarily Meckel's.
Cecal diverticulitis. Okay. Coming to my examination. A patient was examined in a well-lit room with proper informed consent.
wait, go back to the differential diagnosis.
Yes,
Just
sir.
go. After discussion we had just now, will you still put ileocecal tuberculosis as the second diagnosis?
No,
With
sir. No, sir.
presenting acutely, and you said no, never had any other symptoms in the past.
No, sir. I will not put.
No. And psoas abscess.
No, sir.
So then you have to change that thing, and you could have said that I'll appendicular mass, appendicular abscess, but I will change these two differential diagnoses and bring it down.
Yes, sir. Sorry, sir. I will bring both these diagnoses down.
So once the discussion starts, you should be able to learn to change your differential diagnosis, not remain at the same point, right?
Yes, sir.
No.
Okay. So my differential diagnosis by end of the summary will be appendicular mass or an appendicular abscess. Then cecal diverticulitis, perforated appendix, or a perforation peritonitis, sir. So going to my examination. My patient was examined in a well-lit room with proper informed consent in the presence of a male attender bedside. Patient was conscious, cooperative, alert and oriented at the time paralyzed in person. General physical examination, BMI had patient had a BMI of 29. Hydration was maintained, and his performance scale of Karnofsky 70 and ECG 2. There was no pallor cyanosis, clubbing, generalized lymphopathy or pedal edema. So he had a Karnofsky scale of 70 and ECG 2. Vitals, pulse rate was 106 per minute in the right radial artery with normal volume and character, regular rhythm, no radio delay and radiofemoral delay, no vessel wall thickening, palpable or peripheral vessel pulse. BP 130 by 80 millimeters of mercury in the right arm supine position. Patient is febrile. The respiratory rate was 14 cycles per minute, abdominothoracic with regular rhythm. Coming to the abdominal examination. This is an examination of abdomen of a patient. On inspection, the abdomen is flat. Umbilicus is in the midline and inverted. There was no engaged or dilated veins. Abnormal arterial pulses or visible peristalsis can be seen on the abdomen. Right lower abdomen fullness was noted. Hernial orifices, including external genitalia, appear normal. No supraclavicular fossa fullness is seen. Skin over the lump appears normal. No sinuses or discharge of the lump were noted. And only positive finding for insertion was the right lower abdomen fullness. This area was visible on inspection. Coming to palpation, there was local rise of temperature of the right iliac fossa region. There was a tender lump of size 10 to 7 centimeter horizontal to vertical direction, which is present and is occupying the upper right iliac fossa region. The lump was having a surface. All margins were well defined. The superior margin was 10 centimeter below the right costal margin in the mid clavicular line. Inferior mode of the swelling was 5 centimeter above the anterior superior iliac line. The medial margin of the lump was palpable 5 centimeter lateral to the midline, and lateral margin was 17 centimeter lateral to the midline on the right side. On palpation, of the lump there was guarding present. The lump was firm in consistency, immobile, not moving with respiration. The lump was not palatable and is bimanually not palpable. On raising the leg, the lump didn't become prominent. The liver and spleen were not palpable. No other abdominal lump was palpable. Palpation of the renal angles, left supraclavicular regions were normal. Hernial orifices and external genitalia were normal. Both testes were palpable in the scrotal sac. Coming to percussion, the liver span is percussed out to be 14 centimeter. The lump was percussed to have dullness and was not continuously liver dullness. The rest of the abdomen were resonant. There was no evidence of free fluid or organomegaly. No auscultation, normal bowel sounds were heard. No alteration of bowel sounds were heard over the lump. Rectal examination was revealed normal anal tone. No muscles were palpable. Fecal staining was present. No rectal ballooning was present. Systemic examination revealed normal findings in cardiovascular, respiratory, and CNS system. Musculoskeletal system examination also revealed normal findings. So, this is my case summary. A previously healthy 60-year-old man presented with 2-week history of acute onset abdominal pain that migrated from the periumbilical region to the right lower quadrant, later becoming dull aching and aggravated by the movement. He developed a progressively enlarging right iliophosae lump with intermittent fever and recent onset loose stools, without weight loss or urinary symptoms. On examination, a tender intra-abdominal lump was featuring approximately 10 to 7 cm was palpable in the right iliophosa region. The mass was tender, had a smooth surface, well-defined margins, and was firm in consistency. Immobile, not moving with respiration and associated with guarding. The lump was due to an intra-abdominal swelling, dull on percussion, not continuous with the liver dullness, and the rest of the abdominal system examination was unremarkable. This is my summary of the case, sir.
Okay. Go back to your general examination. Yeah. Next. 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 In a MS case, when you are explaining the pulse, I think it is always better to not mention radial and radiofemoral delay, because that is something we don't do, and some examiners are actually very irritated at this finding. Radial and radiofemoral delay would when would you expect a radial delay?
Sir, in
When there is some discrepancy between the left and the right major arterial systems, right? You have a subclavian artery stenosis or something on the right, on the left. When would you expect a radiofemoral delay?
coarctation of aorta, sir.
Exactly. So those are rare conditions. And in any case, you don't do a femoral artery examination when you already have a radial pulse. So it is always better to avoid radial and radiofemoral delay. Okay. Next slide.
Coming to the inspection of abdomen, sir.
Yeah. Now, before you inspect the abdomen, you tell about the attitude of the patient, right? Normally, you won't get an acute case in an abdomen. They are usually not kept. You'll only get cold cases. But one of these acute cases, the patient is supine. He is not willing to move. So, attitude of the patient is to be mentioned. He'll not be walking around, right? He'll not be
Yes, sir.
comfortable moving. So, the attitude of the patient is important here, right? He was supine, and the attitude of the patient is supine. He was not willing to move around. So that gives an idea that there is something wrong intra-abdominal. Okay. So you don't mention gait here, because anyways the patient is lying down, right? It's an acute case. Okay. Next.
Coming to the inspection of the abdomen, sir.
Hmm.
We inspected the abdomen.
Hmm.
Abdomen
Inspection looks good. Next, come to palpation.
fullness were felt here, sir, on inspection. Coming to
Yeah.
palpation, there was localized rise of temperature over the right iliophosa region, sir.
How did you examine the temperature?
The dorsum of the hand, sir.
Okay. So
And yes, sir.
yeah. Yeah. So in what condition there can be a fictitious rise of temperature, when there is not actually a localized rise of temperature, but you feel that the temperature is raised. What conditions will that happen?
Sir, if there is a superficial abscess,
Now, in
subcutaneous.
that case, there will be increase in temperature, right?
Yes, sir.
What I'm saying is fictitious rise of temperature. There is a rise of temperature, but there is no intra-abdominal pathology.
Mm, No, I don't know, sir.
Okay, so basically it's cold. The patient might be having a blanket over it, or he might be applying some hot water fomentation. So those are fictitious conditions where rise of temperature would be there.
Okay, sir.
Right? Okay, and in a patient where it's an acute condition, you'll not be probing the patient too much, right? The superior margin, the lateral margin. If the patient's lump is tender, no examiner would want you to probe around. So it is fair enough to say that because the patient, because guarding was present, which means it is actually tender, it's fair in your right to say that because the patient was having pain, I did not palpate the margins of the lump. You don't necessarily have to find out the margins if the patient is having discomfort, right? So the examiner will not be very kind to you if there is pain and you still probe around.
Yeah.
Okay.
Now, one of the things I can add here, you have written that lump is not mobile. Same thing comes if there is overlying guarding, you cannot assess the mobility of the lump because patient will not allow you to do that. Second is not moving the respiration. On one hand, you are saying that you can reach the upper limit of the lump. Okay. It
Yes,
is
sir.
not in contact with the cost margin or anything.
Yes,
How
sir.
do you expect it to move in with the respiration? Means
Uh,
if it is right left fossa lump, do you expect it to move with respiration?
no, sir.
Tell me one example of right left fossa lump, okay, which will move with respiration.
Sir, the lump is arising from lower pole of kidney, sir.
Lower pole of the
Kidney.
kidney. So kidney moves freely with respiration.
No, sir. It won't move freely with respiration. No, sir. No.
So, and it is here you are saying that tender mass, inflammatory mass, yes?
Yes.
Your history is pointing to inflammatory mass. The inflammatory mass, right left fossa will move with respiration
No, sir.
when you
No.
can reach the upper.
No, it won't move.
No. So don't just say something which you have to say
Okay.
without applying your mind. You are MS candidate, not a MBBS candidate. A student, I will allow this to if he says such thing.
Yes,
At
sir.
MS level, you have to use your intelligence.
Yes, sir.
So better avoid that line, not
Yes,
moving with
sir.
respiration. Yeah, it doesn't make sense here.
Right.
Okay,
Okay.
next slide.
Is that the lump?
Yeah. Why did you examine the testis in this patient?
Sir, one of the differential diagnosis in right iliac fossa uh, lump is that it can be arising as a tumor from the undescended testis, sir. To rule out undescended testis, I examined the testis of the patient.
Yeah. So basically, if you don't see the testis, then you are missing out. You're grossly missing out on something. You have to examine whether the testis are palpable.
Yes, sir.
Since he had drawn the diagram, okay, do you know what are the limits of the right left fossa?
Sir, superiorly by
Surface marking on the fossa.
to mark in the image, sir.
Yeah, surface marking right left fossa.
Superiorly by the transtubercular line, sir.
That is below the umbilicus or above the umbilicus.
Below the umbilicus, sir.
And where your lump, you're drawn
Sir,
half
it is.
below the umbilicus, half above the umbilicus.
Yes, sir.
well above the iliac crest. Okay. So
Mm.
which area it is?
It is lumbar area, sir. The right.
Yeah. So how you are saying it is a right iliac fossa lump?
Mm. Sir, I'm
So
mistakenly
either your
done.
markings are wrong.
Yes, sir.
So you have to be careful. See, in the exam you are marking something and you call it as a wrong quadrant, you will be in problem. Okay.
Yes, sir. The lumbar is actually here, sir. It's marked wrong.
Yeah. So lump is there, then you should mark it correctly.
Yes, sir.
Okay.
Okay,
Yeah.
sir.
Fine.
So Ashik, if you are asked about quadrants, so
Yes,
how
sir.
many quadrants are there in the abdomen?
Sir, there are 4 quadrants, sir.
Yes. So this
And
is
the
the
four
right
regions.
lower quadrant.
Yes, sir. Right lower quadrant.
Yeah. But if you are asked about the 9 regions of the abdomen, then you mention all the regions. Okay.
Okay, sir. Okay.
Just enumerate the lines. What are the lines that make the 9 regions of the abdomen?
There are 2 mid-clavicular lines, sir.
Mm-hmm.
And there will be transpyloric and transtubercular lines. So these 4 lines divide the abdomen into 9 regions, sir.
Okay. So where does the transtubercular line go?
Transtubercular line will go at the level of T12, sir.
No, but what are the surface landmarks for transtubercular?
Sir, tip of the costal cartilage, sir.
No, that's transpyloric, right?
Transtubercular, sir. Anterior superior iliac spine, sir. Both.
And what about the transpyloric?
Tip of the costal cartilage, sir.
Which costal cartilage?
9th costal cartilage.
Yeah. So you have to clearly mention that it's the 9th tip
Yes,
of the
sir.
costal cartilage.
Yes, sir.
Good. How will you
Okay.
calculate? How will you know this is the 9th costal cartilage? How will you surface on the surface? How will you mark?
There will be an acute mm, ah,
It's a vague line of demarcation,
yes, sir.
but the most prominent part of the costal cartilage,
Yes,
that
sir.
will be the 9th costal cartilage anteriorly, right?
Okay.
Okay. So
Okay, sir.
when you say no other abdominal lump was palpable, what other organs were you looking for? What did you examine?
Sir, I examined the kidney, sir.
Mm,
The liver I examined, and splenomegaly also, sir.
okay.
Yes, sir.
ठीक है.
Okay, sir.
Next slide.
And sir, it was a tender lump, but I performed percussion, sir, to look
Mm-hmm.
for the span. And for look for the nature of that lump, sir, the lump was dull on percussion,
Mm.
and it
Better,
continued to the.
better to avoid the percussion on a tender lump.
Okay, sir.
Okay. So
Okay,
anything that causes discomfort to the patient, you might very well say, sir, I did not percuss the lump because it was tender. So that,
understood.
yeah, makes your examiner empathetic towards you, that you
Okay,
were empathetic towards the patient,
okay, sir. Understood.
right?
And rest of the abdomen was resonant, sir.
Okay. Next
And
slide.
and auscultation was done, and I could hear normal bowel sounds.
Mm-hmm.
There was no alteration of bowel sounds over the lump, sir.
Okay. So when you did a rectal examination, were you actually trying to find out any area of tenderness?
No, sir. I couldn't find any tenderness.
Okay.
Yes,
ठीक
sir.
है.
Okay. And there was rectal ballooning, etc. were absent, sir.
Okay. What does rectal ballooning signify?
It signifies obstruction, sir. Bowel obstructions.
Okay. At what level?
It signifies bowel obstruction Below IC junction, sir.
No, any colonic obstruction, right?
Sir. Oh, yes.
Yeah, the rectal will be dilated, right? It will
Okay.
not be filled with feces.
Yes, sir.
What mass you are looking for in a per rectal examination? Go back. What no mass palpable per rectal?
Ma'am, any growth in the anorectum or hemorrhoid?
Hemorrhoid is palpable. And which growth, anorectal growth occurs concomitantly with a cecal growth or a lump or whatever your differentials are?
Mm, Carcinoma? No, ma'am.
So better than writing no mass palpable, you should have looked for what else. If you're thinking of an appendicular lump or a sealed off appendicular perforation, what else should you look for instead of a mass per rectum? What else should you have written?
Blood staining you can look for, ma'am.
No. In contained perforation or an appendicular lump, you'll get bleeding PR.
I will come to your rescue. Particularly, you said the history of loose motions.
Mm, Any pouch of Douglas we can examine.
What in pouch of Douglas? Examine is okay, but examine
Yes.
what?
If there is
Hmm?
collection, if there is any pelvic collection,
Yes, so you have
I
to
can talk.
specifically mention that there's no boggy swelling. That is
Okay.
the specific word that we use. No tender or boggy swelling or, which has some local rise of temperature or something like that. Okay? To just
Okay.
rule out a pelvic collection or a pelvic abscess, since
Okay.
he already has a history of loose stools. Yeah?
Okay. Yes.
And since this is a male patient, you should not mention pouch of Douglas.
Yes, sir.
Yeah.
Yes.
So you just mentioned that no pelvic swelling, pelvic abscess, or pelvic tenderness,
Okay.
right? So you rule out a pelvic abscess that way.
Yes.
Okay. Rectovaginal pouch of Douglas will only be in a female
Yes,
patient.
yes, sir.
Okay. Next
Okay.
slide.
Systemic examination were within normal, sir. Limits
Yeah.
and musculoskeletal examination also normal limits.
Perfect.
This is my case summary, sir.
Just a minute. Since you had put a differential diagnosis of ileocecal abscess, which
Yes, sir.
musculoskeletal system did you examine? This is a very big musculoskeletal system. That means all limbs and everything.
Yes,
Which particularly in the abdominal examination with the mass in the right leg fossa,
yes, sir.
which
I have to examine spine and hip joints, sir.
the spine.
Yes.
Okay.
Both spine,
So
it can track down as
you have
ileus.
to be careful. You don't write vague thing. You should have written the spine
Okay, sir.
normal.
Okay, sir. Understood.
So there was no deformity, no spinal tenderness,
Okay, sir. I will.
and some other test that you do with the lower limb that rules out ileocecal tuberculosis. You did mention that there was no pain in the limb. So any
Sir,
specific test?
flexion. Sir, flexion and internal rotation of the hip joint.
So what will that happen when you do that?
Sir, iliopsoas will get contracted, sir.
So there'll be pain, right?
Yes,
There'll be tenderness. He'll not be able to do that.
yes, sir. Okay, sir. Coming to my summary.
Okay, now give your differential diagnosis. Now you have examined the patient again. So
Sir.
give your differential diagnosis.
In main appendicular abscess, sir.
Mhm.
Appendicular lump.
Okay,
These were my and a contained perforation of the cecum of
okay,
the appendix and perforated diverticulum of the cecum. These are my uh, differential diagnosis, sir.
okay. So why is it not a ileocecal tuberculosis? And what kind of an ileocecal tuberculosis you expect here if it forms a lump?
Will be hyperplastic tuberculosis.
Okay, so now let me ask you, why is it not a hyperplastic ileocecal tuberculosis?
You won't have an acute presentation like this, with pain, etc. The history will be different, and the patient will, the fever present will be like evening rise of temperature, mostly along with setting, etc. sir. And examination also will not have a tender lump, having a duffy sort of mass. Sir.
You may have a tender lump also. It's not necessary that it is acute, but you still may have a tender lump. So ileocecal tuberculosis can still be a differential diagnosis. Because he had fever also, not the classical fever, but he still had, and he had loose motions also, right? So alternating constipation, loose motions may point towards an ileocecal tuberculosis. He might have noticed it for 2 weeks, but he might have had that for a long time.
Okay, sir.
What is the inflammation of the cecum called?
Typhlitis.
Okay. So the typhlitis, associated typhlitis might also be the reason for your loose motions in this patient, right? So appendicitis, because it is very close to the cecum, so associated typhlitis might give rise to the loose motions.
Understood.
Right. Shall we proceed, sir?
Yeah, please.
Yes, sir.
So how will you manage this patient? And by management, I mean both investigation as well as your treatment.
So this was my differential diagnosis. So after the discussion, I will change my differential diagnosis as an appendicular abscess, appendicular lump, perforated cecal perforation, perforation of a diverticulum, ileocecal tuberculosis, and typhlitis. And I am ruling out all the other differentials.
Yeah. So your last two differentials can come up. See, it can also be amoebic typhlitis, right? It can be a cecal diverticulitis. So you have mentioned that, but it will come above the
And
others.
okay. So
Yeah, how will you manage the patient?
I will first I will proceed with the investigations, sir. Investigations to confirm my diagnosis. My manager will be half investigations and half treatment. Investigation first will be routine blood investigation, which mainly focuses on hemoglobin and HbPCV and WBC count of the patient to look for this hemoglobin status and infection rate. Then I will go with the electrolytes, where patient also had loose stool, etc. After the basic serological investigation, I will get an imaging in the form of ultrasound abdomen, sir, because ultrasound is an adjunct to the clinical examination. I will need to look out the organ of origin and the nature and extent of the lump, sir, and also look for lymphadenopathy, the fluid, etc. So I will get an ultrasound abdomen done.
Okay. Suppose this is an appendicular abscess, right? So what will your ultrasound findings show compared to if it is an appendicular lump? So what will the ultrasound show?
You show an hypoechoic collection, sir.
Hyper or hypo?
Particular hypoechoic collection.
It will show hypoechoic collections. Yeah.
The peritoneum, right leg. And ultrasound also has advantage of having gated for drainage also if we find an abscess. In that, ultrasound will be my first investigation, imaging investigation, sir. Then I will with a CT scan.
Okay, now that the ultrasound has told you it's an appendicular abscess, why do you need a CT scan now?
I need a CT scan to look for bowel perforation, sir, with oral and IV contrast to rule out the rest of the bowel.
I'd put it in a different way. I'd say that it is to confirm my diagnosis. An ultrasound will not confirm your diagnosis. Your CT scan will confirm the diagnosis, right? And in all major hospitals, CT scan is available, right? And it's a gold. What's the gold standard of a appendicular pathology?
CCT scan at IV contrast, sir.
Yeah, so you have to go ahead with a CT scan abdomen if it is available, right? And most hospitals will have one. So you do an oral contrast and an IV contrast both, or just an oral contrast?
Sir, because as we are suspecting a perforation, so can do both, sir.
No, can do nahi. What will you do? So this is your case. What will you do? Why are you giving an oral contrast and why are you giving an IV contrast?
The contrast we look for vascularity, sir, and the vessel and the edema, wall edema we have to find. In
Mhm.
oral, to look for intraluminal pathology if there is any obstruction or if there is any perforation.
So oral pathology, oral contrast to look for intraluminal pathology or there is perforation, and IV contrast is to look for the walls of the appendix, right? So they'll be inflamed and they'll light up with the IV contrast, right? Because there is hyperemia. If there is hyperemia, then it'll light up. So basically, even if you don't give oral contrast, it's fine. But in an appendicular pathology, you have to be giving an IV contrast, right? Provided the serum creatinine levels are normal.
Then this is maybe investigation. And if you are no, so this is
Okay. So now that the CT scan confirms that it's an appendicular abscess, patient is fine, pulse is 106, which is not much, but he's running a temperature, right? And the counts are very high. So what will you do for this patient?
then we will have to plan for drainage, sir, because we will have to for extra peritoneal drainage of the abscess. Can do
Suppose the
that.
patient is improving. What will you do? Suppose the patient, next day you go and see the patient, the counts are going down, the fever is improving, and
Then
the patient starts feeling better.
patient start feeling better, we'll go for conservative management, sir. But in our case, the patient is not improving, he's having fever. So we'll plan for a drainage procedure.
Yeah, in this case, the patient is not improving. In fact, he's deteriorating, so you'll have to drain it. What are the options of drainage in this patient?
Then a percutaneous drainage, sir. The extra peritoneal will drain it using an ultrasound method, or we can have an operated drainage, sir. At the point of maximum tenderness, we can give a thin incision, and then we can enter the abdominal cavity. We have to incise the external oblique and internal oblique muscle. And the
No, I'm
passage,
not asking you about the steps of the procedure. Given a choice, what kind of a drainage would you prefer? A percutaneous drainage or a surgical drainage?
percutaneous drainage, sir. Will be guided drainage, sir.
Yeah. Why?
Under ultrasound guided, we will avoid bowel injuries, sir.
No, why do you want a percutaneous drainage and not a intra-abdominal drainage?
Intra-abdominal.
Yeah, you don't do a laparotomy, you don't do a laparoscopy, but you do a percutaneous drainage. Why?
Sir, all the bubble loops will be clamped and inflamed, so it will have the laparotomy or in the abdominal drainage have risk of further bowel injuries. So in that case, we will go for it's better to do percutaneous drainage in such condition.
Yeah, the better answer would be the morbidity is much less, right? It is more comfortable to the patient.
Yes.
And of course, the morbidity of general anesthesia is avoided, right? If you have one, you better do a percutaneous drainage. It's so comfortable for the patient, right? Both cost-wise, the patient is not under anesthesia and the morbidity is so much decreased. You go ahead for a laparoscopic or a laparotomy only if the patient doesn't improve with a percutaneous drainage also, right? So you do a percutaneous drainage, the pus has come out. What do you do next? You send the pus for culture.
The first for routine investigation, including culture and sensitivity, and also we will send for investigation the rule of tuberculosis.
Okay. So what kind of a culture you expect in this patient?
It will be purulent, sir.
No, what organisms you think will be isolated?
It will mix anaerobic more, and more will be gram negative and anaerobic.
Uh, How
What
many times have you seen? You must have treated abscess in the past also. Yes? Or this is the first time?
No, sir. We have treated.
Okay. How many times anaerobes have been grown in the past which you have seen?
No, sir. Mostly gram negative.
Gram negative. So which gram negative?
E. coli will be.
Yeah. So don't be vague in answer. What you have seen, what you have experienced, you talk about that. Okay.
So what gram negatives you said? E. coli and
Like Klebsiella.
Klebsiella. Okay. So suppose you grow anaerobes. So what are the anaerobes that you know of?
Sir, essential coli. Then Klebsiella.
No,
Anaerobes.
they're gram negative. I'm asking about anaerobes. What anaerobes do you get? So you'll have to study that. Okay. So there are peptococci, peptostreptococci, and other anaerobes also, right? What antibiotics will you prescribe for this patient?
Sir, I will start with broad spectrum antibiotics before any culture is obtained, sir. Then I
Mhm.
will treat based on the culture sensitivity.
Mhm. So what broad spectrum you are giving?
Which have gram negative coverage, sir. Give add metronidazole
Okay. Metronidazole is for anaerobes, but what broad spectrum antibiotics you'll give?
and third generation cephalosporin, sir.
Okay, second generation cephalosporins. And anything for the gram negatives specifically?
Uh,
Any aminoglycosides?
Nicotine we can use. Any aminoglycosides.
So basically, it's you give a second generation cephalosporin. You start with an aminoglycoside, either a gentamicin or an amikacin, and then you give a coverage for anaerobes also, right? So that is the basic. And what about the diet for the patient? You keep him NPO, you give him full diet. What do you do?
We
The
will,
patient has been drained, an abscess, a drain has been placed, and this is the second post-op day. Patient is doing fine. He has passed flatters. He's on antibiotics.
we
He's
can
getting better.
do a liquid diet.
So there is no reason to keep the patient fasting, right?
Fasting, sir.
Yeah. What are the disadvantages if you keep the patient fasting for a long time?
The bacteria will translocate to the peritoneum. That bacteria will mobilize to will have peritonitis.
Not necessarily. Yeah, you prevent bacterial translocation, right? So you have to give, at least if not, you have to give water, you have to give some dextrose to the patient, right?
Also,
So
patient.
yeah, what does that help in? If you give diet to the patient, so how does that help?
So he will not have dyslipidemia and he will have wound healing better, sir.
The better answer would be that the mucosal integrity will be maintained, right? So if the mucosal integrity is maintained, then there is less translocation of the bacteria. So I think that is a better answer your examiners will be happy with, right? To keep the nutrition of the patient, nutrition of the mucosa, and keep the mucosal integrity intact. So are there any questions on the chat box?
Yeah. So one of the things, now suppose you have done the drainage of the abscess. Okay. When will you remove the drain?
We will discharge the patient home and we will move after 6 weeks, sir.
Which day of drainage you will discharge the patient?
After 1 week, sir.
How did you decide 1 week? Why not third? Why not fifth day? How do you decide?
Sir, We will monitor the drain output, sir, basically. If the patient is having reduced drain output, decision will be taken. And
Drain
also,
output 5 on day 5.
okay, sir.
What other things you will look for before deciding that patient can be discharged?
We will look for the vitals of the patient. The symptoms are basically the patient is having the fever subsided, and if the general well-being of the patient is improving, and also his laboratory parameters are becoming normal. This
So
noted
what
that
do you mean by general well-being?
if the patient is ambulating and he's having normal soft diet, tolerating soft diet and passing flatus and stools, and patient
Yes.
is
And there is no tachycardia.
not tachycardia. Yes,
And the fever was the main thing, and there's no fever.
yes,
Yeah. Now he comes back after a week.
yes, sir.
Right? What do you look for?
We will look for the drain output, sir.
Okay, 0.
Then we will also look for the fever and tenderness and
There's
the
no fever, there are no other symptoms. He's fine. His appetite is normal.
yes, sir. Then ideally we will have to get an ultrasound done to look for
Okay.
an
Yes. Very good. Very good.
before the drain can be blocked or there will be some collection. So before removing the drain, we should look.
Okay. So the ultrasound shows no collections.
Then we can remove the drain, sir.
Okay. Now you have removed the drain. Patient says, what next for me?
Then we will ask the patient to continue his normal routine diet thing, and there will be small discharges coming from the wound. It will be controlled fistula.
Why do you say control fistula? Did we talk about that there was a fecal matter coming out of the drain?
No, sir, no.
So then,
No, sir.
see,
Sorry.
this is how you start digging your grave.
Yes,
The
sir.
next question will be, what will, if you see the fecal matter coming out, what will you do? You will generate more questions and get into the problem. Just now
Yes,
you
sir.
said no discharge, ultrasound normal, patient having no fever, right?
Yes,
You remove the drain. What
yes,
is the
sir.
further advice?
We will
What
ask the
was the
patient.
cause of this abscess?
It was a ruptured appendix, sir. Appendicular perforation. So we will ask them
What
to
will you advise now?
interval
What will you advise him now?
appendicectomy after 6 weeks, sir.
Interval appendicectomy. Okay.
Okay.
And when do you do interval appendicectomy in a patient who had an abscess? Versus when the patient just forms a lump and so you treat them curatively?
So when
Is there a difference? There is no difference in timing for interval appendicectomy. In two situations, appendicular lump settles down with conservative management. When will you advise appendicectomy? Interval, appendicular abscess, required drainage, and when will you advise the
so if the patient had one more episode of abscess, ideally we advise for 6 to up to 6 weeks.
enlighten him? Hello?
Hello, sir. After 6 to 8 weeks, sir.
Yeah. After 6 to 8 weeks. So it's 6 weeks or 8 weeks, and why?
That appendicular inflammation and surrounding inflammation will be settled. Then we'll be able to remove the appendix safely without injuring the surrounding bowel.
So more severe the inflammation,
Yes, sir. More later we add.
more, yeah, you have to wait.
Or there
Suppose
could
I'll
be
give another.
yeah.
Yeah, please go ahead, Doctor. Please
Yeah.
go.
So basically, there could be a situation where when you do a CT scan after 6 weeks or 8 weeks, you can't find the appendix, right? So the appendix has already autolyzed itself. In that case, you don't have to go in again and do an appendicectomy, right? It's only when you find that appendix, then you go in, right? After an appendicular abscess, In a huge majority of the cases, you might not find the appendix itself. It has already autolyzed itself. Yeah. But of course, if there is a appendix seen, then you have to go in and operate. Why do you wait for 8 weeks or 12 weeks? And
So,
it could be any time after 6 weeks. So it can be 8 weeks or 12 weeks if the patient is fine.
so mainly so that the inflammation will settle, and we will in while appendectomy we will have to have bowel handling. So to avoid injury to the bowel, we wait, and also the inflammation to get localized, and also to get a good base for the appendix.
Yes, the inflammation to the bowels have settled down, right? There will be less adhesions and it will be easier for the appendix to be removed.
Yes, sir.
So then the questions can go anywhere. It can go to steps of appendicectomy. What are the various ways where you deal with the base of appendix?
Yes.
And sometimes the whole questioning can go to the south. That means you are given scenario,
Yes, sir.
you have done the ultrasound, there's a mass, the critical mass with the perfusion. What will you do? So you are taken off from the appendix. So you
Yes,
should
sir.
be immediately for that. What will be your reply?
Hello? Sir, I couldn't
You
hear.
said you had
Hello?
done ultrasound.
So your
CT
voice is breaking.
confirms
Can you
the.
please repeat the question? So your
Okay.
voice is
Can you hear
breaking.
me now? Can you hear me now?
Yes.
Sorry.
Yeah. So suppose I give you a situation that you did the ultrasound,
It's breaking.
Sorry, sir, your voice is not clear.
put a mass in the right left fossa. Okay. Wait, then we can finish discussion. Okay, you can finish the discussion here. Priya,
Yes, sir. Subi, sir, any points to add?
you can.
Hello.
Hello.
Good evening, sir.
Good evening, sir.
No. I think it's very interestingly done. I enjoyed the discussion, but as you know, when there is a right iliac fossa lump, I think you went too sometimes little diverted from your own theme of discussion. And I think you should be little focused and when you really speak on this, especially appendicular abscesses or appendicular masses have to be. It's a very classical training we used to have. Right iliac fossa lump in 3 common and 3 uncommon, we used to always say. So it's like, say, sickle tuberculosis, sickle mass, and first appendicular kind of a lump. And uncommon, then you start talking about undescended testes and all that kind of thing. So first 3 common are your first differential diagnosis. And that's the way, this is a way 60-year-old also. Don't talk about, these undescended testes so commonly. Basically, this is either you have to differentiate from abscess or malignancy. That's your differential diagnosis. So that clinical judgment has to come very quickly, which I think did not come from you. So I think presentation was quite okay.
Available.
You? Hello, Ashish. Good to see you.
Yeah, good to see you, sir. Good to hear from you. How are you doing, sir?
So anybody else wants to add?
If not, then I think we have had a very good discussion. You did well, but then your examinations has to be. It's Priya had already given a disclaimer that we are from the same institution. So whatever, lack of training would reflect on the moderator, of course. So
Oh, no. Don't think that way. Ashish, don't please think that way.
I think sir got offended that he said that in the beginning.
no,
But
not at all, not at
good
all.
discussion. Yeah.
Yeah.
I think it's okay. I mean, students, our students also make equally kind of mistake. It's a question of development. No, you develop once. When you're presenting, when you are doing work, you have a very different way of thinking. When you're presenting, that time you are much more into clinical reasoning and logical thinking. No, I mean that way.
True. True, sir.
When you are looking, you have a CT scan, you have everything in your hand. Here you are going logically. So I think that is okay. This is a part of a training only. I don't think you really make any point. So Ashish.
Right.
Okay.
That is the purpose of keeping these online sessions, so that whatever blunders they are creating, they can create here. So they
Yeah,
are
exactly.
comparatively safeguarded during the final examinations.
Yeah. So when we were talking, I did not tell him all the questions that I'll be asking.
Wow.
Yeah. So he doesn't know what questions would be
Next time
asked.
I should do a blinded, double blinded moderators and presenters.
Yeah. But I think he did a good job. Ashik did a good job.
Yeah.
Good. Definitely,
Yes.
Ashish.
Well
Thank you,
said.
sir.
Okay, take care.
Thank you so much. Bye bye.
Sir, good
Good
night.
night.
Bye.
Bye.
Thank you.